This is very interesting case. Minoka in a radiologist. Basically, this is a radiologist who underwent angiography in other hospital and came to Dr. Mohan for a second opinion. The case is very interesting. This is 40 years old male, had 2 days history of vomiting and diarrhea, and followed by that he had typical substernal pain radiating to both arms and the center of the back on May 27th, 2022. ECG and cardiac biomarkers were performed. There was no past history. He was non-smoker. BP and pulse rate were absolutely normal. These are the reports which he carried. Troponin was raised 12.7 nanogram per ml, and CPK-MB was 48.13 nanogram per ml, and myoglobin in serum 135.89 nanogram per ml. Anti-proBNP was 20 picogram per ml. This was the first ECG. You can see ST changes in 2, 3 AVF and V2, V3, V4, V5, V6. And from here, from the 4th day, he came to us. So this ECG is done at our place, and you can see the changes suggestive of inferolateral non-Q MI. This is definite acute MI by 4th universal definition, presenting with typical presentation, very high cardiac biomarkers and evolutionary changes in ECG. This is the angiography which we later on got from the other hospital to review. They had labeled it normal, and you can see the co-dominant circulation and near normal coronary angiogram, except from this red arrow which is showing mild plaquing at the ostium of the LAD. And these are the various pictures to show the normal coronary angiogram. So we labeled it as Minoka, acute myocardial infarction presented as per 4th universal definition of MI. And he has non-obstructive coronary arteries, that is less than 50% obstruction, no other acute coronary syndrome like apparent cause like Takotsubo cardiomyopathy or myopericarditis or pheochromocytoma is present. In patients with acute coronary syndrome, non-obstructive ischemic heart disease is present in 15% of women and 9% of the men. The potential mechanism of Minoka is it can be epicardial Minoka, non-epicardial Minoka, or Minoka-like syndromes like myocarditis and Takotsubo cardiomyopathy. And the mechanisms can be plaque disruption, coronary spasm, coronary dissection, thromboembolism, demand-supply mismatch, or microvascular dysfunction. From here we started. That ECG was done by us. Then we did the echo ourselves. And this is on the left side, you have a parasternal view. And you can see in the basal inferolateral wall, posterior wall, so there is some hyperechogenicity showing some edema here and pericardial effusion. In the short axis, in the same region, you can see mild hypokinesis along with increased echogenicity. And this is the view, further view to show this. And the 4-chamber view is showing normal, basically. And again, you can see mild pericardial effusion and this inferolateral area, which is edematous and hypokinetic. And in the 2-chamber view, you can see basal inferior wall is mildly hypokinetic with subendocardial hyperechogenicity. So we thought we will do the contrast echo of this patient, which we most often do in maximum patients. You can see the short axis view in the posterior, the same area you can marked by the red arrow, you can see the perfusion defect is there. In all other areas, the perfusion is good. And in this parasternal view, in the same region, you can see the perfusion defect is there. But now the question can arise that it can be an artifact. Posterolateral segment deep to the LV may show attenuation artifact, but this is not, this is true non-perfusion. We'll show you. See, it is not an attenuation artifact because subepicardial layer shows perfusion. You can see here. And these are other views to show. This is left side still image and right side moving image. And this is again to show the perfusion. Now here this basal lateral part is again an area which can give artifacts. So this can be artifact. And then we did MRI, but the problem with MRI is explanation. That is difficult. We did T1, T2 and ECV parametric CMR imaging, and here radiologist had given different report, and the region of interest selected was different, but our region of interest is here, and you can see T1 value which is close to 1400 millisecond. And ECV in this again showed by this arrow, ECV is again near, it is near 40. Though it was reported T1 value 1260 and ECV 24. And this is T2 map on parametric imaging showing significant edema, you can see here. This is the T2 value is 70 to 80 millisecond. And this is the LG, which is, there is no layered gadolinium enhancement in this case. And edema, so there is edema in inferolateral wall at mid cavity and apical region with mild hypokinesis and raised T2 and T1 values. There is no enhancing scar in LV myocardium, a normal LV function and RV function. So this patient has Minoka with inferolateral MI, which we showed by myocardial contrast echo also and was confirmed by parametric CMR imaging. Thank you.
So as the organizing committee has decided not to proceed further, but for the sake of discussion, I think one or two questions may be allowed. Because
Sir is more, we have learned from him.
Definitely there. It is not an attenuation. Though we know that the there is attenuation. Because if you look at the long axis view, the basal lateral wall and the basal septum, there was a distinct difference. So if there is a certain attenuation, it would be there in that entire arc at that depth. So the fact that your basal septum and there was a difference in the basal lateral wall, that was definitely a perfusion defect and transmurally. Secondly, your T2, T1, every map, just qualitatively, even if you look, you don't have to put the ROI. Even if you qualitatively see, they were showing all very light color in that area. So we knew that there is a edema there. So this edema memory persists for almost 7 days to 10 days also. So when was this MRI done?
He came on 4th day and 5th day we got done.
Correct. So that is the best time to. So the culprit vessel identification is one of the strongest. Is one of the strongest quality of MRI because of the edema imaging. But I think the contrast was quite reliable. I mean, we could see the microvascular.
Such
Yeah,
cases of
correct.
Minoka.
Yeah. Only thing I would advise you is that you go triggered imaging. You have a continuous imaging for the microvascular perfusion. So if
that
you
I will tell you,
Correct.
in the machine which now has been provided to me, it doesn't have this feature, but we are getting new machine. We were earlier doing that.
yeah, that's because if
I
you
know,
keep
I
it at the
understand.
end of the T wave, that is the end
And then
systole.
reperfusion you have to see.
Yeah, and just see
And
at
how
every
quickly
end
it
systole
perfuses.
you have got the images, so there is a less destruction of
Yeah,
the
yeah.
vasculature. And an end systole, generally what happens is whatever the capillary volume is squeezed, so it is only in there. So if you don't see the perfusion, you are sure
Yeah,
about
yeah,
it.
yeah. Thanks.
No, it has. Our machine has. Because trigger is there almost in all the machines. E9, no, E9 has it. If you go to the physio,
Or E95 have
no,
triggered
E9
imaging.
you go to the ECG physio, ECG trigger,
Yeah.
and then there is one there is a one ECG trigger. Yeah, it may be on the second screen also. Just search in the physio part of it. Yeah.
One comment I'd like to, madam, whether echo was done before angiography.
No, sir, this is a radiologist who underwent angios from other hospital, and because he was scared, what is the reason troponin I is raised, ST elevation is there, I had typical chest pain, they are saying angio is normal, what
So
to do?
if
he
you
came
have to
for-
stamp it is a infralateral MI, then we have to say it is that there is must be some spontaneous resolution of any coronary artery. If we stamp it as the MI,
The patient has high biomarkers, patient has
now
typical chest
one thing I like to add that whether it is not a case of myopericarditis.
No, it's not a myocarditis. We are showing the MRI pictures also. No?
Yes, that is not fitting with the.
We have done MRI.
Yeah.
Doctor,
So one important thing is that whether echocardiography has been done before angiography, what was the PCAT diagnosis, and after the angiography, then it is very perplexing. But we frequently get this with a MI in the background with a normal coronary artery, and possibility is the spontaneous resolution. But in that case, frequently we get a LV dysfunction, whether due to stunned myocardium or like that, even if it is resoluted.
Sir, this patient, basically we do contrast echo, and when we are 100% sure
Now,
that
one thing is important, what should be the future treatment management? If it is MI, then you have to give specific secondary prophylaxis, antiplatelets like that. And if it is not MI, not coronary, then you have to give something else. So in that respect, it is very important to have a pinpoint diagnosis, whether it is a coronary artery disease related to infralateral MI or something else.
but it is infralateral MI we have.
I think the angio she showed has got some irregularities in the coronary, proximal coronary. So she or he needs antiplatelet therapy, statin, etc. It's not non-coronary. It is related to coronary. So management should be like a CAD disease. Jagdish, I think that's your opinion also.
The whole idea is that, as you said, whether it is spontaneous resolution or it is atheroembolism or it is a microcirculatory dysfunction, you can't decide actually based upon this picture. The point is it is myocarditis because it's regional. It is confined to LCX territory. That tells you that this is not myocarditis.
It is
And of course,
non-obstructive
rapid
but
rise and
coronary
fall.
artery disease.
Yeah.
So it have to treat according to the coronary
Yeah.
artery disease
And
regime.
this rise.
So as the time is limited, thank you for your comments, quick comments. Thank you, Madhu.
Thank
Now we can call upon Dr. Kaustubh Biswas. He will be speaking on and showing cases on heart masses, common and not so common. Kaustubh, please.